Hi, my name is Elizabeth Cho, and I'm a freshman in high school. Today, I will be talking about resistance to targeted therapy in pancreatic cancer and a way to counter it. I personally got interested in this because my grandmother battled pancreatic cancer for 5 years. Current treatments for pancreatic cancer are unreliable. First of all, what is pancreatic cancer? Pancreatic cancer is a disease where cells grow and divide uncontrollably in the pancreas, causing a tumor to form. At 13%, pancreatic cancer has one of the lowest 5-year survival rates. This graph shows 10-year survival rates and clearly illustrates how far behind it is from the other cancers. Here the rate is at 1%, while for all the others it is much higher. So why is it so far behind? There's currently a lack of good early diagnostic methods because pancreatic cancer lacks specific symptoms for detection. At the time of diagnosis, patients often already have locally advanced or metastatic disease. There's also a lack of effective treatments, the common method of treatment being chemotherapy. Other methods are surgery or radiation. Chemotherapy offers modest survival rates, but causes toxic effects, and many patients cannot accept it because of age or frailty. New forms of treatment are needed, such as targeted therapy, which stops specific proteins in the cell from functioning. In order to utilize targeted therapy, we need to find proteins in the cell to inhibit. I'll talk a little bit about cell signaling. All cells need to signal to survive. Cell signaling starts at the membrane. Receptors on the membrane, such as ERBB3 and EGFR, are activated by outside stimuli, such as growth factors. The receptors then signal inside the cell and activate different proteins, such as the RAS protein. RAS then activates or phosphorylates other proteins, which activate other proteins down a long line, which are named by different pathways, such as the PI3K pathway or the MAPK pathway. The pathways eventually reach the nucleus and DNA, leading to regulation of cell growth, survival, and many other things. So what happens when RAS is mutated? KRAS is a RAS protein. The KRAS mutation, which is present in 86% of pancreatic cancers, is the main driver of pancreatic cancer. When KRAS is mutated, it is always activated and is always signaling. It no longer needs to be activated by the receptors. This increases signaling and in the end causes the cell to constantly grow and divide, the hallmark of cancer. Targeted therapy is the future of pancreatic cancer treatment. Targeted therapy targets specific proteins, stopping the signals telling the cell to grow and divide. Targeted therapy has great potential for cancer treatment. However, cells are developing resistance to targeted therapy. There's been a lack of success in clinical trials. I will talk about 2 different clinical trials today. The first is for a KRAS inhibitor called sotorasib. This drug specifically inhibits mutant KRAS. This trial was conducted among patients who had previously received at least one systemic therapy. This diagram shows survival probability over time in months of progression-free survival. Progression-free survival means the time of how long the patient's tumor is not growing. It is not the same as survival rate, so every drop in the graph doesn't mean the death of a patient. It simply means that a patient's tumor started growing again. As you can see, probability dropped pretty quickly. The second is for a MEK inhibitor called selumetinib. This trial was conducted among patients who had locally advanced or metastatic pancreatic cancer, most of whom had already received 2 or more lines of chemotherapy. This diagram also shows survival probability over progression-free survival in months. As you can see, the results are not much better. While these trials did not completely fail, we would think that they should work better. If the inhibitor permanently inhibits a protein which is along the main lifeline for the cell, how can the cell continue to survive? Resistance. I will be talking about 3 different types of resistance, specifically to MEK inhibitors. Of course, there are many other mechanisms of resistance that I will not be able to cover today. The first mechanism is activation of parallel pathways. When MEK is inhibited, the MAPK pathway here is also inhibited, which should stop the cell from growing. However, one thing that the cell can do is activate other pathways which go to the same end, such as the PI3K pathway or the STAT3 pathway, which will, when we look at studies, it will look as if the treatment is not working. It is important to note that these different pathways are just possibilities for the cell to revert to, and there's no guarantee that this will happen. The second resistance mechanism is reactivation of receptors. When RAS is mutated, there are different types or isoforms of RAS in the cell, and only one of them needs to be mutated in order for the cell to become cancerous. So when MEK is inhibited and the MAPK pathway is inhibited, the cell can actually reactivate these receptors at the membrane so that they are always signaling, and they will then go and signal to those isoforms of RAS which have not been mutated, and they will still prove to help the cell grow and divide. The third resistance mechanism is reactivation of the MAPK pathway. When MEK is inhibited, one thing the cell can do is actually cause MEK to undergo a genetic change so that the inhibitor can no longer bind to it, which will lead the cell to just go on as it was before, producing resistance. So with all these mechanisms of resistance, what is the answer? Dual inhibition is the solution. There's been success in preclinical mice trials. The first is for a MEK inhibitor called trametinib and an mTOR inhibitor called omepallisid. In this graph at the top, it shows tumor volume over time. This red graph is vehicle, which means without treatment. The green is for the mTOR inhibitor, the blue is for the MEK inhibitor, and this teal color is the combination therapy. As you can see, the combination therapy caused the tumor to grow very little compared to the other treatments. This graph at the bottom shows probability of survival. And as you can see, again, this teal color, the probability of survival stays much higher for much longer with the combination therapy. The second trial I'll be talking about today is inhibiting KRAS and this receptor ERBB3. In this graph at the top, it shows tumor weights. And with the control, that means without treatment, it is much higher than the combo, which is combining the therapies. And this combo is again much lower than these other treatments on their own. Probability of survival stays much higher for much longer with this purple color as well. We can take any two of these targets and this is our arsenal of current FDA-approved drugs. And we can take any two of these targets and swap them to stay in front of the cancer and eradicate it once and for all. I'm hopeful that these treatments will improve survival rates for pancreatic cancer patients like my grandmother. Thank you for listening. Any questions?
Great job, Elizabeth. Thank you so much. I think you told a really clear, I love the way you presented it, and it was really clear and informative. Super interesting to me that, such a high percentage of cases are all associated with that one gene and one mutation. I didn't know that. So that's really interesting to me. Thanks. Yes, so if anybody has other questions, feel free to put them into the Q&A. I have a few of my own that I'd like to talk through first. So talk to me a little bit about this resistance problem, and is it kind of unique to pancreatic cancer, or is this kind of a problem and solution that we're seeing across different cancer types?
Yeah, so I think this is definitely not specific just to pancreatic cancer, as of course any cell can undergo these different types of resistance. And yeah, I just focused on pancreatic cancer because I have that personal connection.
Yeah. Great. Let me read something from the Q&A. Great job. What do you recommend as the most effective combination treatment to try in clinical trials?
I'm not sure. Sorry.
No worries. But I think the evidence that you presented, you showed a few combos that are great. And I think it's thinking about the ability of trying different things in kind of your last slide where you outlined all the different um, potential targets is super interesting. Great. And what about you? What do you hope to do next? So you're just starting out in high school. What is next for you in academic life, research life? What are you thinking?
Yeah, so I'm hoping to try to get internships at like real labs to do research there. And I'm also like interested in the patient side of things, so maybe trying to shadow some doctors, see what that's like.
Awesome. That sounds great.